right, so we'll go ahead and get started with our last speaker for this morning. I'm going to introduce Dr. Bill Berrigan. He's actually a physical medicine and rehabilitation physician and an assistant professor here. He did his residency training at Georgetown and then his primary care sports medicine fellowship at Emory. And then we convinced him to come out west. He's one of our newer faculty along with myself. Dr. Berrigan's research interest focuses on orthobiologics as well as ultrasound, both from a diagnostic and interventional standpoint. He has a lot of experience with both ultrasound and orthobiologics and is kind of our lead go-to guy for these topics and issues. And he's going to be talking about orthobiologics and ultrasound in sports medicine. So give it up for Dr. Bill Berrigan.
Thanks, Nick. Thanks, Nick. Appreciate that. So my goal for you guys today is to really start to understand what an orthobiologic is. More importantly, what's the evidence base behind everything that we do and why. And then I'll also get into a little bit about ultrasound, how I use it in biologics, and also how you can use it within your practice. These are my disclosures. I'm a key opinion leader for Samsung and a co-investigator in a trial looking at exertional compartment syndrome sponsored by Ipsen. These are objectives for today. And before we get started, you're always a product of your mentors. So this is my Emory family, and specifically Ken Mountner and Robbie Bowers. A lot of this will be a reflection of the talk. So what are orthobiologics? Well, it's where you utilize your own body's cells to promote some healing or damaged tissue. So we are cellular beings. There's over 37 trillion cells within our body. And at any given time, 15 million of RBCs are being regenerated and turned over. So the question is how can we utilize these cells to better help our body heal? Well, there's four specific generations that I'll be talking about today. One is platelet-rich plasma, which I'll go into a lot of detail about. The other is bone marrow aspirate concentrate. And then finally, lipoaspirate, where we take the own fat tissue which is rich in cells as well. And then I won't be talking about amniotic tissue and umbilical products today. The reason being is that in order to have this injected, it has to be under a clinical trial. So there's no longer approval by the FDA to use these products without the use of a clinical trial. So why do we need this? Well, if we look at the literature in orthopedics, only 19.6% of the total volume of procedures performed are supported by at least one low risk of bias RCT that shows that surgery is superior to non-operative alternatives. Now, this has actually increased over the years, and this isn't really a knock on surgery at all. This is saying, well, if most things are non-operative, how can we optimize this? How can we get better at what we do? And traditionally, all we do is treat it with these methods like Price. So we protect the tissue, we rest, ice it, compress it, and then elevate it. And this has slowly been changed over the years, where we now follow this peace and love model, where we're protecting and elevating and compressing it, but really we're working towards a load progression and optimizing kind of the mental aspect of return to play. Now, what you also notice here is that we tend to avoid anti-inflammatories, and I'll go for this in a second. So if we look at the injury and tissue repair, there's three separate phases. There's inflammation, there's maturation, and proliferation. So you need inflammation to help tissue heal. Well, non-steroidal anti-inflammatories block that inflammatory phase. So theoretically, you're prolonging that time for tissue to heal. And for most sprains, strains, and these basic injuries, we really don't have evidence to use non-steroidal anti-inflammatories. And I know I'm preaching to the choir here, where we know that NSAIDs aren't without their side effects. So we have GI ulcers, exacerbation of heart failure, cardiac issues, renal issues. All of these things we need to consider, especially in our older athletes or for those with comorbidities. Well, then, if NSAIDs aren't the answer, and peace and love doesn't really do everything, well, is steroids the answer? And what we really need to start paying attention to is that steroids are more detrimental than they are to helping the patient in tissue healing and cartilage healing. And so when we look at osteoarthritis, and in this systematic review looked at the effect of intra-articular corticosteroids, you can see that there's actually a dose-dependent deleterious effect on cartilage. And so what that means is if we use more steroids or if we higher dose of steroids, we're actually doing more harm than we are doing good. And so then when we look in clinically, we start to think of, well, if we do multiple steroid injections, that will help the patient, they'll feel better. But this looks at 10 randomized clinical trials and showed that there's inferior or non-superior symptom relief compared with other injectables using steroid at the 3-month period and beyond. Now, this isn't anything surprising to us because we always knew that steroids were short-term effects. But what do we do in the long run? And so that's where some of these injections like hyaluronic acid or PRP and stuff that we'll talk about today come in. So this is the forest plot looking at it. So A is that 3-month mark. We see that the corticosteroid and others are pretty similar. Then once you get to B, which is 6 months, and C and D, which is 9 months and 12 months, we're really seeing that we're favoring these other treatments that were in these trials. So then we look at the need for this. Well, there's an estimated that 18 million people are living with osteoarthritis. And 13.9 of those 18 million people are responsive to conservative measures. Then we look at about 0.5 million of those are going on to knee arthroplasty. Well, that leaves 3.6 million people that are in this treatment gap where they're not responding to the conservative traditional measures and they're not ready for knee arthroplasty. And this number is even increased throughout the years. So then we look at the cost of this on healthcare expenditures, and we see that about $27 billion is being put into this, and $100 billion when you consider the loss of work that is associated with this. And then we see also that the number of total knee arthroplasties in the next 10 years or so, from 2010 they looked at to 2030, is supposed to increase by 73%. And that treatment gap, when we look at individuals, they're living in this treatment gap for an average of 9 to 12 years. And in our younger patients who really aren't ready for knee arthroplasty, they're living in this for an average of 20 years. So then we look at cost-effective analysis as to average cost per quality of life, or so year of quality life, and how much you actually get benefit from it. And we see that the only treatment that falls within the category of being cost-effective and able to provide treatment effect is total knee arthroplasty. But when you look at the numbers of total knee arthroplasty, you still have 20% of patients that undergo this surgery that aren't necessarily happy with their knee arthroplasty. And then if you look at the typical osteoarthritis patient, they're really only willing to pay up to $5,700 per quality adjusted life year. So there's no knee osteoarthritis treatment that offers the ideal combination of this clinical effectiveness with the willingness to pay threshold. So that's osteoarthritis. Well, what about tendinopathy? So are corticosteroids the answer for tendinopathy? So we asked Michael Scott. No, we can't. So steroids are not the answer for tendinopathy either. So if we look at the systematic review of really an in vivo and some in vitro studies, about half and half, we see that there's decreased collagen organization, decreased proliferation of fibroblasts, decreased collagen synthesis, and this all changes the mechanical properties of the tendon. And the only thing that increases is actually necrosis of the collagen and cellular toxicity. So you get all these inflammatory cells that aren't necessarily helping with the process. If we look specifically at the rotator cuff, it showed similar properties in terms of collagen, extracellular matrix, and the formation of these tendons. But what is important to note from this study is this can happen as early as 24 hours after an injection, and it can last up to 2 to 3 weeks. So we look at the efficacy of steroids, and this is published in The Lancet, that showed that corticosteroid, when compared to like physical therapy alone, has pretty much similar benefit, and that's what we're seeing here. And so when I counsel my patients, I'm saying, well, we could do a corticosteroid injection with physical therapy today, and we know that at about 6 to 8 weeks, 3 months, you're going to be in about the same boat as those who didn't have the corticosteroid injection. And then you're only essentially weakening the tendon within the process. And we see that corticosteroid, when compared to other treatments as well, placebo injections, PRP, isn't having that good effect when we look at intermediate and long term. And this is including different studies looking at intra-articular non-steroidal anti-inflammatories, other placebos. And again, the short term, we'll see that there's some relief in pain, but long term, intermediate, it's not giving an effect for these patients. So I just talked about how we shouldn't be using steroid around tendon or into tendon. So especially when we look at things like tennis elbow, we know that this doesn't have effect long term, and it increases the risk for re-injury. And so the good news is that the trend is decreasing. So we look at the orthopedic surgeons that actually utilize this, and in 2010 we were at about 23% that were still treating tendinopathy or this lateral epicondylopathy with steroids, and now we're down into the 18% level. Now that still leaves 18% that are using this, and so we need to ideally that level starts to go down. Well, then what do we do? So we got to do something. And so this is where we start to bridge the gap for these treatments. And we bridge the gap by certain treatments like biologics. So when I talk about biologics, we'll first talk about platelet-rich plasma. So what is platelet-rich plasma? Well, it's a concentrated cellular milieu of products, of venous blood. So we take the venous blood, usually it's about 30 to 60 mLs or cc's of blood, spin it down to just the platelets. Well, the platelets are rich in a lot of growth factors. So then you deliver a supraphysiological level of growth factors to stimulate the body to heal. Now, there is debate within the field of actually what constitutes PRP, and not all PRP is created equal, and that's important to note. So some people will say that it's 1.5 times the amount of platelets in the baseline that creates PRP, but most people now are leaning towards this 5x or 10x times the platelets to really say what PRP is. So that's 5 times the amount of platelets that you have in the physiologically. So how does it work? Well, platelets they have a lot going on. So they have a lot of granules, and they release different enzymes and catecholamines and have different effects. But what we care about is the alpha granules. So when we look at the alpha granules within platelets that are released, they contain cytokines and these growth factors. And when we look at what they are specifically, we have this list here, which is platelet-derived growth factor, TGF, VEGF, EGF, and also fibroblast growth factor. And what they do is they stimulate cell replication, angiogenesis, they promote epithelialization of new tissue, and they promote this granulation tissue formation. So what does it do? In summary, it activates and releases proteins. It has these anti-inflammatory properties, inhibiting NFKB cells and target cells and these matrix metalloproteinases, which are actually destructive to cartilage and tissue. And then it promotes this extracellular matrix remodeling. So how does this work in osteoarthritis? Well, osteoarthritis is wear of cartilage on both sides of the joint. And so what's involved in it is these catabolic factors, looking at IL-1B and TNF-alpha. And these stimulate matrix metalloproteinases, elastases, and leads to chondrocyte apoptosis. So in the PRP is IL-1 receptor antagonist and tissue inhibitor matrix metalloproteinase inhibitor, which counteract the degradative process. So we start to enhance this IL-RAP, which is IL-1RA, TIMP, and type 2 collagen to promote a healthier tissue or healthier environment for the joint. Now, we're not regenerating cartilage, but we are providing this, this healthier environment and strong anti-inflammatory process for the joint. In tendinopathy, we have to think about it differently. So we inject the PRP into the tendon, and that tendon, then the PRP is activated by the intrinsic collagen fibers. And this initiates a healing cascade. So we need to understand what the healing cascade is. So in order to understand the healing cascade, you have to know the stages of wound healing. So there's inflammation, there's repair, and there's remodeling. So when we look at inflammation, this is a vascular response. So this lasts several days, and it's bleeding and vascular disruption, and this leads to the activation of the coagulation cascade and thrombin. Well, that thrombin activates the platelets. And then you start to get all this blood flow or edema within the area that it causes local blood flow permeability and release of these different properties. So this lasts for about a few days to a week. And then we get to phase 2, which is the tissue reconstruction or repair phase. So this is anywhere from about 2 to 6 weeks. And so this is where the growth factors start to stimulate fibroblasts, they increase collagen and lay down granulation tissue, but the tissue isn't as strong as we would want it to be. So then after about 6 weeks, we get to this third phase, which is the remodeling and functional restoration phase. And this is where type 3 collagen fibrils and type 1 collagen is then laid down. So we're starting to get a remodeling of the collagen and the tendon to create stronger tissue. And this goes along with the rehabilitation process after PRP for a tendon. So most people, when I'm treating them, they won't be going back to sport for about 2 to 3 months, and we're not escalating their high-impact plyometric activity until that 6-week mark when we know that we're laying down this thicker collagen tissue. So where is the evidence? That's what's most important, right? So when we look at osteoarthritis, there's level 1 evidence for the knee. There's also evidence in the ankle, hip, SI joint, and CMC. And the American Medical Society for Sports Medicine, which is our society that we look to, has put out this principles for regenerative medicine and using the responsible use. And within it, it has the summary of the meta-analysis and systematic reviews for different joints. And we can see that there's 14 positive systematic reviews and meta-analyses that support the use of PRP in knee osteoarthritis. The next one underneath that is the hip, but we also see it for the ankle, foot, and hand. So I'll go through what these are. Well, this was published in the OJSM about a year ago, and it's the most recent meta-analysis that looks at PRP. It included 21 trials, and the PRP was compared to corticosteroid, saline, and hyaluronic acid injections. And what they found was that PRP injections are beneficial for both pain relief and functional improvement when we look at knee osteoarthritis. So this is what we see that if in this forest plot is that compared to HA, corticosteroid, and the saline, you're constantly seeing that you have an improvement with the PRP compared to the control. So hyaluronic acid is one of the treatment methods that I also use for knee osteoarthritis. But how does that compare? How does that line up to when we look at PRP? So this is a systematic review that was published about a year ago, again, in the American Journal of Sports Medicine, looking at level 1 studies that are comparing hyaluronic acid and PRP. There's 18 studies total with 811 patients that received PRP and 797 that received hyaluronic acid with a mean follow-up of 11 months. And what they found is that there was an improvement in functionality that was significant in the PRP group more than in the hyaluronic acid group at 12.6%. And for those studies that use visual analog scale and pain, there was a better improvement with PRP than with hyaluronic acid. And there's some good low bias studies in here that are showing that it clearly favors PRP within this forest plot. And this is less than 12 months and greater than 12-minute follow-up. So some are in the field, they're like, well, PRP is beneficial, hyaluronic acid is beneficial. Can we combine the two? So this review looked at the combination of it, and it was a total of 13 articles for 1,100 patients, looking at functional measures like WOMAC, KOOS, and also pain levels with the visual analog scale, and found that there was not a superiority with the hyaluronic acid and the PRP compared to just the PRP alone. And the thought behind this is that if you don't know what the hyaluronic acid is doing to the PRP. So it might be actually diluting those platelets. So we might be delivering less platelets than we actually know, or we don't know what we're delivering. And the same works the other way around. So does the PRP have an effect on the molecular weight or the consistency of that hyaluronic acid? So that's one of the debates that we're talking about within the field. And this is just the forest plot showing that there's no difference between the two. So I talked about everything for the knee. Now, if we look at the studies for hip osteoarthritis, they are less robust. But this is published in the Journal of Arthroscopy in June 2022, and it showed 6 studies with 211 patients that had PRP, 197 patients received hyaluronic acid. They looked at functional measures like the WOMAC and Harris hip score, and they also looked at pain levels. And they found no significant difference between hyaluronic acid and PRP. Now, why is this important? Because if insurance companies do not approve hyaluronic acid for the hip, and so when we look at the true cost of PRP and hyaluronic acid out of pocket can most of the time be more expensive than when you're paying for PRP, depending on where you go. And if you really investigate the contents of these studies with the PRP, some of the studies didn't even quantify what was in the PRP, how many platelets were delivered, and then the machines that were used sometimes didn't even concentrate a supraphysiological level of those platelets. So we really have to dissect the literature to see why something is not working. This was just published last month looking at shoulder osteoarthritis, and gosh, we need something for shoulder osteoarthritis because we know that the replacements, they just don't have that same longevity. And so this looked at 70 patients, hyaluronic acid compared to leukocyte-poor PRP looked at functional measures with the SPADI and also pain with numerical rating scale, and found similar improvements with both groups. But again, this used about 3.5 times the amount of platelets, which you always wonder if they used a higher dose PRP, if it would have worked better than the hyaluronic acid. And so this is what we're looking at these groups. So they went about from a 7 out of 10 to a 4 to 5 out of 10 with the two treatments. So in tendinopathy, AMSSM position statement on regenerative medicine also put out some recommendations and meta-analyses that are used for tendinopathy. And we see that the highest level of evidence is more in lateral epicondylopathy, but we also see that in patella tendinopathy, rotator cuff, and Achilles. And we'll go into these in detail. And so if we look back, let's say like 10 years ago when we first started to report these patient-reported outcomes from looking at PRP and different tendons, this was a study done by some of the leaders in the field, an average age of 48 years, 36 months of treatment that wasn't responding. They had all tried everything besides the PRP, and they did PRP under ultrasound guidance. And so you had a total of 325 patients and 180 respondents, so you get a 55% success rate. Not ideal, but still good. And they looked at retrospective data such as improvement, the visual analog scale, and satisfaction. And what we see is that 82% of patients reported moderate to complete improvement with tendinopathy, and 70% reported 75 to 100% improvement with the PRP. And if we look specifically at pain scales, the average score before a PRP was a 7, and then we go down to a 1.8 after the PRP. This is a 74% reduction in pain with this treatment. So they also looked at the different tendons and how successful each was. And so again, lateral epicondyle, so the common extensor tendon, gluteus medius, these are all more successful than we see. And the patella tendon is a lot harder to treat, which was evident within the study. So that's all good. That was about 10 years ago. So where's the evidence now? Well, we have level 1 evidence that it works for gluteus medius tendinopathy, lateral epicondylopathy, and rotator cuff tendinopathy. And there's some evidence also within the Achilles and patella tendon. So this is a study that looked at leukocyte-poor PRP, or leukocyte-rich PRP compared to corticosteroid, 1-to-1 allocation, a level 1 study. They used 6 to 7 milliliters of PRP with 5 to 6 needle fenestrations. So this is a high dose of PRP, and they found that there was sustained improvement of the leukocyte-rich PRP compared to corticosteroid. And corticosteroid really only had benefit up to that 6-week mark. And when the great thing about this is the patients were eligible to cross over to the PRP group. And what we see is that the patients that had to cross over, so they had already received steroid, they still did just as well at that 2-year mark as those that didn't receive a steroid. So it's not the end of the world if they do have a steroid injection and then eventually have PRP, as they still have similar outcomes. When we look at lateral epicondylopathy, this is published recently, I think within the past year, in the OJSM. We see 26 studies. It looked at patient-reported outcomes, VAS, QDASH, PRTEE, and looked at several different time points out to 104 weeks. And they looked at the difference in comparison with the the clinically important difference that is needed. And so when we see here is that with all these functional measures, we're seeing close to an 80% improvement from baseline with these treatments that last up to 104 weeks. And the only thing we didn't see it is in the PRTEE, which is a different outcome measure for this, but we still see improvement in most of the scales. Well, everyone will argue it's not the PRP, it's the needle. You're doing needle fenestrations, that's creating inflammation, and that's what works. Well, this has been looked at. So we look at this study in the AJSM, found a success rate at 12 weeks for those in the PRP group was 75% versus 65% in the control group. And even more important is at 24 weeks, we see an 83% in the PRP group compared to 68% in the control group. And this is looking at least 25% in improvement in symptoms. So this is also something that I educate my patients on. If we're going to do a needle tenotomy in office, we have about 2/3 will respond. But when we look at specifically at pain, you have 71.5% with the PRP improvement and 56.1% with the control group. Looking at the rotator cuff, we also have level 1 evidence that this works. So this is 8 randomized clinical trials, 6 with low risk of bias, 4 compared to normal saline, and 4 compared to rehabilitation and dry needling, and found that PRP was safe and effective intervention for this long-term pain control in these patients. And we look at the forest plot for this, and again, we see at the 3-week mark, we wouldn't expect to see much difference with PRP. But when we get out to 3 months, 6 months, and beyond, we're seeing that it favors PRP over the control. So I talked about tendon, talked about osteoarthritis in the knee. Well, there's a lot more people that are talking about PRP and muscle injury. So this systematic review published in 2018 in the journal Arthroscopy looked at grade 1 or 2 muscle strains and found a reduced return to play time with no difference in the re-injury risk rate. Now, this was not the same for hamstring injuries. So when we're looking at this and you investigate what the studies show, it's really only like a couple days in terms of return to play, some up to about a week. So in your professional athlete, a day or two earlier return to play, that's thousands of dollars. That's coming back to the team. That's getting to play another game. But when you're looking at your recreational athlete, 1 to 2 days, 1 week, not usually worth it for the cost of the PRP. So these are all things you have to consider. And some are arguing that it's not even the PRP, it's just the aspiration of the hematoma that's leading to an earlier return and recovery time. So some of you might have heard like leukocyte-rich versus leukocyte-poor. Well, this is a big debate in the field, and really it's this arm wrestling match as to what works. And traditionally, leukocyte-rich PRP was for tendons, leukocyte-poor PRP was for the joint. But we're seeing there's a lot more to it than just saying it has leukocytes. And so this was published in 2022 looking at leukocyte-rich PRP versus leukocyte-poor PRP in the treatment of knee osteoarthritis, and found that there was no difference between the two. And they used a high-dose PRP. So maybe it's not leukocyte-rich or leukocyte-poor. Maybe it's what you deliver and how many platelets you're delivering to get to that level. And in tendinopathy, there is evidence that actually leukocyte-rich PRP can be more damaging to tendon. And when we look at the neutrophils, they can degrade the tendon more than anything else. And so what we need to be thinking, is it neutrophil-poor PRP or is it neutrophil-rich PRP when we look at this? And so this systematic review is published this year, looking at this for lateral epicondylopathy, showed no difference between leukocyte-rich PRP and leukocyte-poor PRP for this treatment in a total of 26 studies with 2,034 patients. Well, JAMA published this study and has a really cool name, Restore, randomized clinical trial. It's easy to reference for patients, saying that PRP compared to saline, it does not work. So maybe it doesn't work. And then the Bone and Joint Journal, JBJS, very high impact journal, also said that there was no evidence that a single or multiple PRP injections work. Well, this is starting to get puzzling. And then another one came out and said that there's no clinically important difference with intra-articular PRP in hemophilic knee osteoarthritis. So what do we do? Do we throw all the PRP stuff in the garbage? Do we throw these trials in the garbage? Do we use it to learn more? And so we start to think about what to do. And what I challenge you to do is to know that dosage matters. And that's what we're starting to realize in this field. And so if we look at each trial, so the Restore randomized clinical trial, which is published in JAMA, and you have to go all the way into the supplementary to really find how many platelets were delivered. It was 325,000 platelets that was compared to baseline. So you're really barely meeting 1 to 1.5 times the amount of normal platelets within the body. And then the total dosage delivered was 1.625 billion platelets. If we look at the peak randomized control trial, the platelets that were given was 372,000. Again, not very much, maybe 1.3 times the concentration. And the total dosage delivered was 1.49 billion cells, billion platelets. And then the third one only delivered a dosage of 3.75 billion cells. And so what I challenge is to say, well, this does give us evidence, but what it gives us evidence for is that maybe low dose PRP doesn't work and we need a higher dosage. And so that's what's starting to be being challenged and looked at within the field. So we look at this PRP and knee osteoarthritis trial and that delivered greater than 10 billion platelets, and we saw a significant improvement at the 1 year mark. And then that study that I just mentioned, looking at leukocyte-rich versus leukocyte-poor and knee osteoarthritis, they were delivered greater than 5 billion cells in each treatment group. So that 5 billion number is what we're starting to talk about. We need to deliver more than 5 billion cells into the joint. And so this has led to call for standardization. So there's multiple different calls, and when you're looking at a paper, you really need to understand what we're delivering, what the drug is. I mean, you're not going to, as a clinician or a physician, you're not going to deliver an unknown dose of a drug for an unknown period of time at a unknown, unknown what the drug actually is. So we need to start figuring out what our platelets are. And so this is a classification system by Mountner and colleagues that looked at platelet count, leukocyte concentration, RBC, and activation, because these are all what should be reported in the literature currently. And then we look at this Marspill method, which is another method to report what the PRP is. We need to start looking at what the spin, how many platelets, was it image guided or not, what was the leukocyte concentration. So these are all things that need to be reported in the literature. And I argue in most high-level journals now will not take any sort of study that doesn't report these types of values. So I talked a lot about platelets, but what about mesenchymal stem cells or signaling cells, or what I'll argue and I'll talk about is medicinal signaling cells? So this is also in the responsible use for regenerative medicine procedures in the AMSSM. And it's known as a busy slide, but if we look at what can actually be used in the United States, we have one, which is platelet-rich plasma, which we just talked about, and not a true MSC, but it can be used within the US. Two is bone marrow aspirate concentrate. So this is where we take your own bone marrow, which is rich in cells, and then inject it within the tissue. Now it's important to know that when you concentrate it down, that's okay by the FDA, but it can't be taken out and cultured, because that's not approved by the FDA. It's more than minimal manipulation. So if you see any studies that are out there on that, that's done outside the US. And then we also have this microfragmented adipose tissue, which we take the adipose and wash it down, which is also high within cellular content. Now we can't do enzymatic digestion of the fat because that's also not approved by the FDA, but that's what some studies will show as well. So there's two types of stem cells. There's mesenchymal stem cells and there are hematopoietic stem cells. And so the mesenchymal stem cells are found in adipose, dermis, synovial fluid, periosteum, umbilical cord tissue, and elsewhere. Now the hematopoietic stem cells are different, but what we're starting to think is since the hematopoietic stem cells can actually convert to MSCs, maybe these are starting to be the generator or what orchestrates bone formulation. And so is that the true driver? More questions to be answered. So what happens with these MSCs? So if there's some injury to tissue, then the body will respond with macrophages and granulocytes to help clean up that tissue. And then the cytokines will also come within the area. And they activate these pericytes. So pericytes are just cells that are right next to the blood vessels. And they're actually been shown to be rich in MSCs, or pretty much synonymous with MSCs. And so then they're activated and they act as these medicinal signaling cells. And so these medicinal signaling cells have immunomodulator activity with the T cells, B cells, and then also when we're looking at trophic activity, it's just anti-apoptotic, anti-scarring, angiogenic. So you're creating this regenerative microenvironment. Now what we aren't doing really is seeing that these cells are being multipotent like we would think. Really, we're starting to see that it's more of a drugstore. And so MSCs really stem cells, or are they just this drugstore? And this is a concept that was proposed by Arnold Kaplan, who was one of the originators. And since the MSCs are active at different sites, and the pericytes can be isolated from vascular tissue, they secrete all these bioactive factors and immunomodulator activities. So they're actually providing direction, just like a drugstore, rather than actually differentiating into this tissue and to create this environment. Well, how do we harvest the tissue? So with bone marrow, we go into the posterior superior iliac spine, which has been shown to be rich in the most amount of cells. We take it from 3 separate sites with 10 cc syringes to maximize the cellular counts. We process it into a centrifuge, and then we get about 8 cc's of BMAC. For MFAT, it's like a mini liposuction. So we harvest from the lower abdomen. You can also take it from the thigh as well, depending on the patient. Then you get about 60 cc's. You infiltrate 120 cc's of tumescent, which is just a lot of numbing and fluid that helps extract the tissue. You wait about 15 minutes, and then you take out 30 cc's of fat. And then that washes it and you get down to about 9 cc's of the microfragmented adipose tissue. So why would you use bone marrow versus adipose? Well, adipose does have more MSCs than bone marrow by concentration and volume, up to 500 times the amount. Well, we think that bone marrow may actually have more potential for osteogenesis and chondrogenic properties. And clinically, we haven't really seen a superiority between the two. And what's the evidence for these treatments? Well, we have level 1 evidence that this works for pre-collapsed vascular necrosis. And this is within the hip and also within the knee. And usually this is accompanied with a core decompression type procedure. We also have level 3 evidence that works for knee osteoarthritis, and more trials are starting to come out to look at its impact. So this is what we looked at. This is what we looked at bone marrow lesions, and which means AVN, osteoarthritis, and also osteochondral defects, and looked at the evidence for MSCs within this condition. And so I'll go ahead and pull up with the table that we had, and it's busy, but if we look at the conclusion, all of these studies showed a significant improvement in pain and function with BMAC. Now, some of them didn't really show a difference between the placebo or whatever it was comparing it to. So there is more work to do. And if you really look at the studies, there's different ways to extract the cells, and so not all of them were optimized. Looking at MFAT versus bone marrow aspirate in knee osteoarthritis, this was a retrospective review of prospectively collected data. We have 110 patients with 76 adequate follow-up on a total of 106 knees, and there was no difference between macrophagomatic adipose tissue and the BMAC procedure. But we see all of the KOOS scores that are increasing from their baseline with both treatments. Interestingly about this is I did look at Kellgren-Lawrence scale, which is a scale looking at the degree of knee osteoarthritis, and found that once you get to the 3 and 4 level, which is the more severe grades, it's about a 50-50 shot that it works. And this is what I would counsel my patients on. So then we're looking at 2-year clinical outcomes and how this works. So this is a study looking at 75 patients, 120 treatments, the mean age of 70, so this is our old elderly population, and found an 88% response rate with the treatments at 2 years, and only 11.7 failed prior to the study endpoint, and failure was considered knee arthroplasty or another treatment of these cellular therapies. And so as we would expect when we look at Kellgren-Lawrence scale and the degree of osteoarthritis, the KL4 grades did not respond as well as the KL3 and the 2. What they did look at is, could something predict a response rate? So they looked at KOOS ADL and found that those with higher functional demands did not improve or did not report the same success rate with a higher KOOS ADL than those with a lower one. What about at 3 years? Well, this looked at 30 patients, 23% received, only 23% received additional treatments. And we look and see that at about 12 months to 3 years, it kind of levels out from how they did at that time point. And has anything been compared to PRP? Yes. So bone marrow aspirate concentration has been compared. Didn't really show a difference. Again, there were some methodological flaws within it, but so there's ways to see if we can optimize it, look at cell counts. And then there's macrophagomatic adipose tissue, which more and more studies are starting to come out that it doesn't necessarily have much of a difference between PRP. And then if you look at PRP versus MFAT, this is a really well done study, and they delivered 13.68 billion cells with platelets into the joint. They found no difference between the PRP and the MFAT at 6 months time period. And so this is what we're looking at all within pain and function between the two groups. And then this paper in arthroscopy, looking at a meta-analysis of 43 studies, shows that adipose-derived MSCs were the best treatment option. So maybe we're looking more at longevity with these treatments than the comparison between the two. They did show that leukocyte-rich PRP and leukocyte-poor PRP did have an effect, but only the adipose was at 12 months was shown to have an improvement in the VAS. Bone marrow, so to say, there was too much to compare, too much variability. So everyone will ask, well, are these even safe? We're taking these stem cells, deliver them, or signaling cells, and Centeno and colleagues looked at this, and they looked at 3,000 procedures and 2,300 patients, follow-up of 2 years. There was 18 clinical facilities in this, and there was only a total of 325 adverse events. And what these adverse events were just mostly pain related to the procedure or pain from progressive disease. There's only 7 neoplasms that were reported from this, and this was lower than the incidence within the general population. And the lowest effects were seen within bone marrow. So there's a lot of questions than answers with this. Why did it work? Is there a genetic component? Is it the amount of cells? Is it a specific protein? I mean, there's only 1,500 proteins within PRP alone. Why did it fail? How do we make it better? This is things that we are constantly looking at in the field, and we'll see within the next 10, 20 years that this will evolve and we'll start to get more answers. So here's our takeaways today. With PRP, there is good clinical evidence for certain conditions: mild to moderate knee osteoarthritis, lateral epicondylopathy, tennis elbow, gluteus medius tendinopathy, and plantar fasciopathy. And PRP is more of this generic term where we need to start defining the ideal counts, the dialeukocytes, how many injections are needed. Is it 1? Is it 2? Is it 3? And then what's their ideal rehabilitation protocol? All this needs to be studied. And when we look at MSCs, there's even less answers that we have out there, but this should be the cornerstone of what we start to look at. And as we need to start understanding the trophic and the secretory effects of the MSCs and what the difference in mechanism of action is between tendons and articular cartilage. So we don't know the optimal source, route of delivery, carries, scaffolds, all these sorts of things can be looked at. So I told you I'd talk about ultrasound as well. So what I use ultrasound in my practice for is mostly diagnostics, so I'll do it as an extension of my physical exam, and then I'll use it for all my injections and treatment options. So when I use it for the diagnosis-wise, this study showed that when you compare it to MRI, there was no difference between ultrasound and doing the MRI, and obviously there's a learning curve with ultrasound. And when you look, and especially with the improvements in ultrasound over the past 10, 20 years, is that the sensitivity and specificity of using ultrasound for these conditions and looking at the tear has significantly increased, where there's not much of a difference between the two. And you can identify those tears which you're going to treat specifically with these treatments. And then what about ultrasound guidance? Well, I use ultrasound guidance for all of my injections. The literature supports it. When we're looking at a glenohumeral joint, there's a 20% difference between an ultrasound guided injection and a landmark guided injection. Look at AC joint, there's one study even showed a 40% with a landmark guided versus 100% with the ultrasound guidance. And there are some that still are more landmark guided, like the knee and subacromial space. But it's always nice to see exactly where the needle is going and what you're treating. And then when we look at the hip joint itself, the standard of care is used to use imaging. It's such a deep joint. And so the success of the landmark guided injection is about 66 to 77%. And there's so much neurovasculature within the area that could be of issue. But when we look at it with ultrasound, we're at that 97 to 100% mark. It's easy to visualize it going into the joint. So their conclusion was basically that upper extremity ultrasound guided injections make sense. There's evidence that it supports the use of it in terms of finding where the needle goes and doing the treatment, and also within the lower extremity as well. So what does it look like when you do these types of injections? Well, so this is the joint here. And so you see the ball and the sockets, the humerus and the glenoid labeled. And then from superficial to deep, we start to see the starry night appearance of that infraspinatus, which lies over the joint. And then you could see the needle actually going straight into the joint itself, and it goes into the capsule and fills that whole capsule. So how we can use this in biologics also is blood draws. So simple. Just if it's a tough stick, you could identify the vein, take it out. For the bone marrow aspirate concentrate, I'll use it to identify the posterior superior iliac spine and look at the different planes of which I would redirect the trocar. And then for microfragmented adipose tissue, you could use it to make sure you're not within and near any specific structures, although that's not always done. So with the future of this and some of my research interests in terms of what we're going to start to see within the field is the use of something called elastography, which is looking at stiffness of tissue. So if we look on the image on the left, you see that this is a calcific tendon. So the white area, that white area is the calcification, and then the tendon is all within that fibrillar component. And so when we look at elastography will, if a stiff tissue will be red and less stiff tissue will be blue. And so you could see that there's an increased stiffness in this patient with tendinopathy in that area. So what are we going to start to look at? Well, when we do these treatments like biologics, we need to start to show objective evidence that there is change with what we do. And it's tough to do that without some sort of technology that can evaluate the stiffness. So we're looking at mechanical properties of tendon, and we're able to follow that over time and correlate with our patient-reported outcome measures. And we could also start to develop more sensitive means for diagnosis of tendinopathy, see who's at risk, especially within our professional athletes, to, if this tendon isn't very stiff, or if it's more stiff or on the borderline, should we start to do some rehabilitation with these athletes? And so that's what my current area of research interest is, and what we'll start to see within the field. So thank you. Take any questions.
Thanks, Dr. Berrigan. We'll start with a couple of questions that are from the folks at home. One question is, what is your opinion of alpha-2 microglobulin protein with PRP, or can you comment on that?
Yeah, so alpha-2 macroglobulin is kind of a trapping protein. It's found within the platelet-poor plasma. So it's commonly referred to as A2M now. And so there's not a whole lot of evidence of A2M in terms of what to use it for. So I've been pretty cautious with my use of it. Mostly I will use A2M for like recurrent effusions within the joint, so that it kind of traps it and then lead to reduced effusions. But that's the only indication that I have. Some people are using it for like muscle injuries. It doesn't make as much sense to me, but that's all that I've been using for A2M. So the HCCs is what's found. It's more that like all the machines out there are not created equal. So there's over 51 machines on the market, and only 11 produce a true concentration that could be constituted by some as true PRP. So it's really about getting the centrifuges able to produce a higher number of platelets, and then making sure you deliver the correct. If it's usually it's just 8 mLs within the joint, or 7 or 8 mLs within the joint. But I wouldn't do necessarily more like 16 milliliters of fluid within the joint. And you would have to also take out more. You'd have to take out more venous blood from the patient as well. So it'd be like a couple kits if you do that. So it does take time. For the tendon, I'll see it usually at 3 months. We'll see some of the best improvement, and then up to 6 months. But that's because they're starting to return to the sport. With osteoarthritis, you see some difference at that like 1 month mark. And so that's my protocol at least goes through a 1 month protocol after doing it within the knee. And kind of the first week you're resting, second week you're doing more motion, and then third and fourth week you're starting to progress with your activity and plyometrics and things like that. So I would say about 4 weeks you start to see for the joint, 3 months you really see it for the tendon.
Some of these kits have that double spin feature. Like I use the M-Site kit, and the argument is you can get about 20, even above 20x.
Right.
So I kind of agree that it's probably more about the quantity than the concentration. Now, when you talk to Chris Centeno and Regenix, these guys do that lysate, right? So they do the flash thawing and freezing and stuff. Last time I looked, there was no evidence that the lysate was superior to just leukocyte poor. And some people actually add calcium chloride to the PRP, because the argument is that that creates lysate as well. So I wanted to get your thoughts on that. And the second question I recently had a patient that had a gastroc muscle tear. She's a professional Frisbee player. Nice. And I used the PRP and I mixed it with this, it's called MVASC. It's microvascular matrix. It's dried up. It's like Botox. And you dilute it with saline. And in this case, I diluted it with PRP. And there's a lot of interest in that. It's called MVASC. And basically, I injected her, and the second time she came in for a second PRP injection last week. And I looked at the area of defect, and it's near completely healed where the tear was. So I'm wondering if you've heard about these microvascular capillary matrices like MVASC.
Yeah, so I've heard of it. I'm not sure of the evidence behind it. I don't think it's been well studied yet. I mean, for burn patients. Okay.
Thing with the CEO, and the presentation was that the orthopedic surgeon who basically injected the supraspinatus tear with it just one time. And then the pre and post MRI, it almost looked as if he'd gone in and done a complete rotator cuff repair. So they're very excited about it.
It's interesting. I mean,
I'd be interested to talk a little bit more offline too, to check out what that would look like. But if we're seeing those types of improvements and like anecdotally, and we're seeing case reports, that's just a basis to do more studies, right? So if that's the case, then that's great. We get our professional athletes back sooner. We see that there's changes within the muscle tissue itself, which is likely it could be correlated with strength. And so I think that's a great tool. In terms of platelet lysate, yeah, I agree with you. There's not much out there, and Centeno and colleagues, they drive a lot of the evidence, but they keep a lot of their studies secret at RegenX because it's their own platform. So I've seen them use it. I don't exactly know what their usage is for it. I know there's talk within the field to use platelet lysate for something like adhesive capsulitis, where you're actually breaking up. You're using some of the proteins to help break up some of that tissue or some of the adhesions within the area, and that's been more successful. But I think the research is still out with platelet lysate. Maybe they'll share it with us at some point. Yeah, exactly.
Well, that takes us right to noon, so I want to make sure you all have a lunch. So thanks, Dr. Berrigan, for the great talk.
Yep.